Thank you very much, Jeremy. Vice Principal, Professors, fellow academics, ladies and gentlemen. A great pleasure for me to be here today to give this inaugural lecture back in my alma mater of the University of Glasgow. Anna, I'm healed, you'll be glad to hear. I thought I would say a little bit about myself before you hear about some research. It's an interesting journey, and one of the things I would like to say today by way of encouragement is that, yes, you can grow up in a rough council estate in Kilmarnock and still be appointed as a professor in a Russell Group University, which is a fantastic and great plus both for the education system in the United Kingdom and in Scotland, but a big plus for the University of Glasgow as well. So 3 cheers to the university for its endeavours. So I was born not many miles from this Burns's cottage, and initially life was a bit tough because we moved shortly to Kilmarnock, and I was an Ayr United supporter but living in Kilmarnock. And you can imagine I got my head kicked in on a regular basis, to use the modern parlance. So I learned to use the tongue quite vociferously and robustly, and I think that was a major help in achieving some of the things that we've done within my professional life and career. I'm a great admirer, as were many generations before me in my family, of Robert Burns, and you don't really see much of me between about December and March as I'm on the circuit singing and speaking at various Burns suppers. But Burns has been a huge inspiration for me. He's an inspiration because he talks about the downtrodden. He talks about those in life who get a raw deal and those who are impoverished. And there is no doubt that the teaching of Robert Burns, the inspiration of Robert Burns, has fed into a lot of what I am and much of what I do as a clinician and as a teacher. I did have the advantage of having 2 fantastic grandparents. This is not them. One of whom was a farmer and looked after pedigree Ayrshire cattle, and the other one was a gardener in a big house outside Ayr. And I took much of my early interest in observational studies through watching both of these men at work, and my interest really in the genetic aspects of life as well through watching these Ayrshire cattle be bred and developed. And in fact, a little known fact is that I first of all applied for vet medicine in the University of Glasgow and clearly was nowhere near good enough and didn't get a place here, so went off to do this very poor relative of dentistry, and then had the audacity to do the 3rd poor relative and do medicine. So I'm not quite sure how that sits at the moment. Other major influence in my life has been a faith journey, and one of my exploits was to spend some time in San Salvador in Central America, and hugely influenced by the teachings of Archbishop Oscar Romero, Roman Catholic Archbishop of San Salvador, who was in fact killed for his beliefs as he said Mass in the beautiful and historic Cathedral of San Salvador. So another pivotal part of my life. And then my coming of age really was some time spent in Charlotte, North Carolina, one of the most beautiful cities in the world you might ever meet. Those were the individuals that finally affirmed this wee boy and decided that I could probably do something with my life after all. So taking all of those things together, that's who I am, and I hope that you'll come with me now on an interesting professional journey. The first paper I ever published was in 1987, and it is the best paper I've ever done, bar none, because it's of huge practical clinical relevance. So this is myelodysplasia presenting with a neuropathic entity where you get altered sensation around the trigeminal nerve system. And is it important? Yes, it's important, because just 3 weeks ago I saw an elderly lady at clinic who presented with unilateral mandibular division paresthesia, and lo and behold, she's got myelodysplasia. So these are always very important and helpful clinical pointers in one's journey. So I guess that was the first challenge for me about putting the mouth back into the body, and you'll see that as a recurrent theme as I go through my presentation today. And then we've kind of come full circle a bit in dentistry, because we fought for years to get outside medicine, because medicine were far too overpowering and far too bombastic and far too took the lead in everything, and dentistry were left at the poor cow's tail. And then we've tried to come back a little bit, and some of the really exciting things that are happening at the interface between medicine and dentistry I'll say something about today. But there has been a plea, I think, from the dental profession to put the mouth back in the body. And did it happen in 1760 or 1820? No, it didn't, and it's still happening, that we must get this mouth back into the body. And here we are with another statement, this time from the other side of the Atlantic, from the National Institute of Dental and Craniofacial Research. Oral health is not an independent entity which is cut off from the rest of the body. Rather, it is woven deeply into the fabric of overall health. And so that takes us to headline-grabbing papers like this, where it says, saving lives, toothbrushes trump seatbelts, where the implication is that such is the potential impact of the microbiome and the processes developing within the oral cavity, that they have a profound systemic effect. And one that Anne, I'm sure, will be delighted with, floss or die, the link between oral health and cardiac disease. A huge push in that direction. Is there good science behind it? Well, we've yet to see much of that, but these guys would suggest that you would be better flossing your teeth than taking your statins. And that's a huge challenge, really, is it not? So there is a potential link between the oral cavity and systemic disease, but we need to explore that, develop it, and evaluate it before we can make these kind of profound headlines. So regardless, it's an interesting time within the oral health industry. It's an interesting time for science and for clinicians working within the oral medicine and wider dental environment. And I want to take each of these areas in turn today, me as a clinician, me as a scientist, although not even touching the feet of a great scientist that you've just heard from here in the forum of Sean. And I do thank you, Sean, for being the most erudite warm-up act that I've ever been involved with. Thank you very much for that, even better than John Paul Leach. And then the third thing would be teachers. So I want to talk about all of these things. And why is that important to me? Because one of the things that's profoundly important to me as where I'm at in my life is that we ensure that we give the highest quality educational experience for our students. That when they leave the University of Glasgow, they don't just leave looking for a job, but they leave inspired to be the best clinicians, the best scientists, and the best teachers they can possibly be. And I want to find our students of star grade right in the middle of that, so that they benefit from all that we can offer them in each of these domains. So I want to share with you a little bit of my journey in research. First of all, in educational research as a teacher, around clinical research, touching on epidemiological aspects of oral cancer, and then finally in this area of orofacial granulomatosis and oral Crohn's disease, claiming to be of some scientific worth. So again, trying to put the mouth back into the body. One of the very obvious things when you work in clinical dental practice in oral medicine, at the interface between medicine and dentistry, is that doctors know very little about oral disease. They claim to know much, and they actually know very little. So when we look, first of all, at the training in oral disease and diagnosis for medical students in the United Kingdom, things are not good. And in fact, things have not really improved significantly in that domain. We can do better with that. And then this paper in green at the top here, which was our first fire into the whole issue of professionalism. And this really came around through 10 years of chairing fitness to practice at the General Dental Council, and realising, I thought, and proved to be true, that there was a change in the movement of professionalism. So these stuffy, suited individuals who were sitting, passing judgment on fellow professionals, I wondered if they were perhaps a little bit out of sync with the rest of the population, and particularly a younger population. And lo and behold, that's exactly what this research showed, that the modern young mind is not remotely concerned about whether I, as a professional person, smoke dope in my spare time, as long as that smoking of dope does not impact upon their treatment as a clinician. But they're certainly really concerned about my abilities to engage with them with eye contact and ability to speak with them on a one-to-one basis at the chair side or at the bedside. So there's a big change happening in medical professionalism out there. And then we took that into an interesting IT-based project where we asked medical, dental and nursing students about how they would judge their fellow professional students in various breaches or lapses, as we would see them in professionalism. And that was a fascinating study, and that has shown that the young dental students, the young medical students, the young nursing students develop a culture of professionalism and become much more like you or I might be as they evolve and develop through their professional course and their professional career. We then took this into looking at how professionalisation looks in the context of how ethnicity impacts upon it, and that too has been a very interesting journey as well, because ethnicity can impact upon our understanding of professionalism. And then finally, looking at clinical medical sciences for undergraduate dental students, and we have developed in recent times a curriculum which is nationally and indeed internationally driven, so that we can be similar or the same in our understanding of the educational process. The next aspect I want to talk to you about is oral cancer, and for many years have been involved with an interest clinically in oral cancer, and it was a delight to come back to Glasgow and be involved with the group led by Professor Lorna McPherson and Dr David Conway, both of whom are here today. This is one of the prizes from Glasgow, looking at this educational pack for doctors, dentists, pharmacists and others in a Scottish and in fact an international context, since it became a prize-winning educational pack across the globe. And we looked at a number of issues, particularly the role of the primary healthcare team and how we might improve the ability of the primary healthcare team at all levels, medicine, dentistry, pharmacy, to improve the early detection of oral cancer. And that has been a fascinating journey. In terms of future work, this is a classical oral cancer, as you might see here. We're looking at how we might further and better implement clinical guidelines in relation to oral cancer to improve the patient's journey and early diagnosis, and then also looking at opportunities for opportunistic oral cancer screening and what the impediments might be to that in a clinical context with PhD students working in both of those areas. The final bit I want to talk to you about today is an area which grew out of my PhD, and that's this area of orofacial granulomatosis, or oral Crohn's disease. And yes, there have been some headline-grabbing headlines over the years, and of course, as many good science projects are, they are fallen into because there's a sudden realization that something is happening that we could pick up upon. And one of the things that happened early on in this project was a realization that with swelling of the mouth and lips, I wondered what these individuals might be consuming. And I worked out very quickly that the majority of these individuals were consuming in excess of 1 litre of fizzy drinks daily. Okay? Now you might want to put that into a really interesting context, because if we take one interesting and favoured carbonated beverage in Scotland and one variety of that, you might wish to know that the average Scottish consumption of that is 26 million litres in any 1 month period, which equates to 4.5 litres per citizen, man, woman, child, neonate and geriatric. And believe me, the neonates do get it sometimes in any month period. So what's in this stuff which might make these kids develop a hypersensitivity reaction? So this OFG term was introduced by David Wiesenfeld, who in fact was working in Glasgow at the time that he introduced this. He's no longer here. And he called this a constellation of signs resembling those of Crohn's disease clinically and histologically, but in patients who do not appear to have abnormalities at other sites in the GI tract. You know about Crohn's disease. I don't need to give you a lecturette on Crohn's disease. But you know that it's a gastrointestinal disorder primarily, but it is a multi-system disorder as well. And we know that orofacial manifestations are common, and they tend to present with diffuse swelling of the lips, the cheeks, with cobblestoning, mucosal tags, and this interesting gingivitis picture as well. What you might not know, though, is that the microbiome aspect of this was actually first suggested by Sir Kennedy DL, who was a Glasgow surgeon, and he operated just down the road here, in fact. And his brilliance was not only that he was a surgeon, but he was a part-time farmer, and he identified that Johne's disease that he was seeing in his cattle, his pedigree herd of shorthorns at Helensburgh, were exhibiting exactly the same things that he was seeing in adult and child subjects with inflammatory bowel disease. And Dale operated, it is recorded, on 5 similar cases over the next few years, and then published his findings in 1913. However, it had been trumped already by Crohn, by Burrell B. Crohn, who published the landmark paper in 1932, which now bears his name. But what's also interesting is that the whole microbiological aspect of Crohn's disease is now back in the frame again, and I'll say something more of that just in a second. Although the first orofacial case of Crohn's disease was described by Dewdney and Todd in 1969, again, just a short history lesson. Some of you will be aware of Archibald Pitcairn, who was a co-founder of the Royal College of Physicians of Edinburgh. Sorry, Anna, I know you've put your head down at this point again, and it can come up shortly. And it's recorded now as well. So Archibald Pitcairn was a physician to the House of Stuart, and in fact looked after some very famous individuals, including Charles Edward Stuart. And he describes having been called to the house of Traquair one night, Lady Anne, who was the eldest of 17 children, and she was bleeding from her tail end, but she also had this swelling of her lip. And it seems likely that in a Scottish context, for the first time, orofacial granulomatosis was inadvertently described. We also know that the signs of the orofacial signs of Crohn's disease can predate bowel symptoms by several years. They may only ever be limited to the orofacial region, and some of those with orofacial lesions may have asymptomatic Crohn's disease. And we also know from the studies that we've done that the more involved the mouth and face is, the more likely that that individual is to have underlying gut Crohn's disease. So this is the kind of appearance that we see in our predominantly teenagers and young adults with orofacial granulomatosis, this brawny swelling, upper and lower lip swelling, this strange cobblestoning of the oral mucosa, fissuring, which is also seen, of course, within the gastrointestinal tract. And then for me, one of the most fascinating things of a demarcation line, an inflammatory line. Why would this hypersensitivity reaction suddenly stop? What is the immune process that causes this to cause all the cardinal signs of inflammation, and then suddenly it stops at one part in the mouth? And then we have those with fistulation as well. We also know that there are 5 other types of mouth inflammation or stomatitis associated with Crohn's disease, and the one that was described in Glasgow in 2000, this staphylococcal mucositis, which again puts the microbiome back very much in the frame, and I'll say something of that just in 2 minutes' time. Gut inflammation in OFG does exist, and we're tempted not to call that gut Crohn's disease, but simply part of the spectrum of OFG, and we now consider it not indicative of early Crohn's disease. And in the long-term follow-up studies that have been done both in London by Campbell and Escudi and by ourselves here in Glasgow, we reckon that the risk of Crohn's disease developing in someone who has pre-existing orofacial granulomatosis is about 15% at 20 years. So the majority of these folks maintain the inflammation around the head and neck region. But we also know that there are increasing risk factors for the development of Crohn's disease, and these are the ones that are on the screen here. So if children get this before the age of 16 years, if they've got a posterior pattern, that's an oropharyngeal pattern of oral disease, certain types of ulceration, and raised inflammatory markers early on, all of these would tend to point towards an additional risk for Crohn's disease. So what about our understanding of the immunogenetics? Well, I'm not going to say much about the immunogenetics of Crohn's disease because that would be a 2-day symposium in itself. We have some understanding that OFG patients may have some alterations in NOD2 and CAD15, as in Crohn's disease. We're beginning to see some early oral presentations on that, but nothing yet has filtered through to the literature. We also know that there's an influx of T lymphocytes in these mucosal biopsies, and that they do undergo some clonal expansion, and that this T cell receptor beta variability suggestive of delayed hypersensitivity is very much to the fore. We also know that they are Th1. They have a prominence of Th1, which is similar in some studies to gut Crohn's disease, and we have this interesting species or interesting type of subepithelial dendritic B cells, which are away from lymphoid tissue, and are an interesting entity and are thought by some to be part of IgE expression and IgE-mediated allergic reactions. And so this takes us to a point where our understanding fits exactly with the paper published by Brostoff from London at the tail end of last year, that both Crohn's and OFG may in fact be a type 1 and type 4 hypersensitivity reaction working together. From some of the work that we've done with serological markers looking at HLA typing, and that is substantially outdated, I understand that, we just are seeing two different types of presentation emerge. So it's looking very much like the background genetics for the HLA typing, in particular for Crohn's disease and for OFG, are really quite different, and so probably different diseases. So finally, the etiology. We know that Crohn's disease is a multifactorial illness. We know that there is interaction of genetics and environmental factors producing immunological dysregulation. We know that that was probably triggered by a number of environmental factors and sustained by some form of abnormal immune response. We also know that there are strong and substantially replicated associations with polymorphisms in various genes, NOD2 and others. And we know that there is abnormal intestinal permeability in Crohn's disease. And we also know that that's the case in many patients with underlying orofacial granulomatosis. So the question is, going back to that suggested by our Kennedy DL here many years ago, is it Mycobacterium paratuberculosis, as suggested by John Herman Taylor? Is it Saccharomyces? Or is it some other form of food product or toothpaste? Well, we know that it's not Mycobacterium paratuberculosis from the work that we've done in Glasgow. We know that these individuals show significantly increased levels of both type 1 and type 4 hypersensitivity reactions to benzoates and cinnamon and indeed other food compounds. And increasingly we're also seeing them reacting both in delayed and immediate hypersensitivity to dental materials, in particular to amalgam. So we know that it's not Mycobacterium paratuberculosis that we're looking for, but we wonder about other entities, including Staph aureus, which was first described as an entity in Glasgow here, and also the possibility of Saccharomyces. We do know that these kids with OFG have underlying gut permeability issues, and we also know that they've got certain HLA types suggesting a genetic background, and that there is a role for food allergy and hypersensitivity in the development of their disease. And there may in some also be a contribution from reactions to dental materials, in particular mercury and amalgam. So the future work, we're already involved on the phenotypic and genotypic data gathering with our colleagues Jeremy Sanderson in London and Jack Satsangji in Edinburgh, and involved in the GWAS study in both of those centres. We also are looking at our GDOC study at the moment, looking at the immunopathogenesis of OFG and Crohn's disease, and in particular microbiome and mycobiome in the mouths of patients with OFG and Crohn's disease, and their genetic predispositions for each of those diseases. So ladies and gentlemen, in conclusion, let me suggest that we very much need to put the mouth back in the body. Not just because it's important that we get some scientific answers, but because as clinicians and academics, we also have to have healthy and powerful mouths to be the advocate in many circles and circumstances for those who are still downtrodden and need an assistance on the way up. Let's not forget that that's a major role for us as well. So thank you very much for your time.
Any questions for? Thank you very much. We enjoyed that immensely. I just wanted to touch on the point of you just touched on the periodontitis.
Yes.
I still remember when I was a youngster back in the day when I used to go to the emergency department and spend half my life there and see a range of patients, and you could smell cancer. You could say, well, I think that person's got cancer. I want to try and find them. And now we're finding that periodontitis, bacteria is associated with certain cancer types. You see a big incidence of cancer in Glasgow, and there's an issue with dentition. What do you think is the chicken or the egg? Do you think they're getting the periodontitis and of particular bacteria, because they've got the cancer, in fact, people have tried to train bees to smell cancer.
Yes, indeed.
Or is it the reverse? Do you think that it's the risk of periodontitis over many years that be exposed to cancer?
Very good question. We certainly know that dental neglect is an independent variable, an independent risk factor for mouth cancer, for head and neck cancer. And in fact, David Conway is the man to ask all about this. This is David's major study across Europe. So we do know that poor educational attainment and dental neglect are two independent risk factors. So it would be very difficult to look at how periodontal disease, which is a disease state that you get in people who are for the majority, are low educational attainment and have dental neglect. It would be difficult to try and sort out which are the cofactors there in the development of mouth cancer. And the other aspect to that is that tooth loss, and again dental neglect and tooth loss, leads to traumatic environment within the mouth. And somewhat that Peter Lockhart did in the States some years ago suggested again that trauma within the mouth is an important risk factor for the development of mouth cancer. So all of these together are interesting variables, and it's very difficult to try and sort out which of those is the chicken and which is the egg. Very difficult.
Thank you. That was really very interesting. Just following up on Andrew's question, I guess the same could be said for cardiovascular disease, and I think the thinking now in our world is that these are really epiphenomena.
Yes.
Because how do you explain that patients who are edentulous, by definition, shouldn't have periodontal disease, and yet they are at high risk as patients who do have?
Sure, but of course the question there is, when does the cardiovascular disease start? And that's a danger, I think, that we say, well, they're edentulous, and therefore there is the microbiome or the disease process in the mouth can have no influence on the systemic disease process. I think that's a really flawed argument, because the studies that have been done looking at dental experience prior to being rendered edentulous means that they are important risk factors for the periodontal disease, the dental neglect, the caries, and all of that stuff has clearly happened from an early age. So when do those risk factors become important for cardiovascular disease? So I bat it back to you and say, when is that issue important?
Could I join this debate? You probably remember that about 10 years ago, maybe a little more, there was a big study from UCL looking at periodontal disease and early stage of cardiovascular disease as shown by forearm studies, just looking at early endothelial dysfunction. And the group that did it, and you remember this, the group that did it had a large number of patients. It was published in New England Journal of Medicine. It was a very strong paper, then criticized by many. And I think you're right, there's never been a proper answer. So I wonder if that can be done in Glasgow, having all the skills together, and maybe there is a collaborative project to do.
And I think this is something that Marta Gibson is
very interested to do.
Yes.